Dr. Wojcicki, thank you.
Okay, and I will say that I'm super happy to be interrupted if anybody has specific questions. When we go to this screen share view, I sort of lose the ability to see everybody's faces. So if you just want to unmute and shout at me or put something in the chat, I am happy to stop and discuss whatever seems interesting. Okay, if you could carry on there. So as I said, I do a lot of work with different populations. One of the things that pediatric psychologists do a lot is work in an integrated way with kids who have some kind of hospital involvement, right? So all of the subspecialties that are present in the hospital, things like cardiology or nephrology, GI clinic, endocrine, all those things that those medical specialties that kids might be involved in also typically have a role for pediatric psychologists, whether we're helping kids deal with kind of the sequelae of chronic illness, or whether it's an acute event like a trauma related issue. There's typically kind of a role and a way for pediatric psychologists to be integrated. So here at the New Children's Hospital, we have integrated in a number of different specialties, and a service that I was involved in, I have been since I came here about 8 years ago. And then even prior to then, when I was doing my training, is the pediatric gastroenterology service. And it turns out that there's sort of a couple of different ways that mental health kind of plays into GI physical health in particular. You can go forward. I think about it as a series of overlapping circles. So there are things that kids deal with that are kind of that belong to the mental health side of things, belong to behavioral health. They belong in our diagnoses. They're things that maybe a kid would show up at, at a behavioral health office for, but also have physical sequelae. So we all sort of know the feeling of maybe sitting, in a roller coaster waiting for it to take off, where you kind of feel like your stomach is doing flip-flops, right? So there are lots of ways that our brain can impact kind of the feelings in our stomach, and things like anxiety for kids often get expressed somatically, and felt somatically. So a kid who's dealing with anxiety or trouble separating or different kinds of chronic stress may be experiencing kind of belly symptoms. Lots of times, I mean, if you are a parent, if you ever work with kids, if you work with parents, you'll hear about kids who are nervous about maybe going to school, and so they'll say that their stomach hurts. It could just be a sort of a way to try to get out of what's going on, but it's also really likely that they're probably having some kinds of belly symptoms, because our brain, when it fires up that anxiety response, that stress response, one of the places that response shows up is in our GI system. So a kid could have kind of belly symptoms because they're having a classic sort of behavioral health diagnosis. So that's kind of the one circle. The second circle, the second big circle, are kids who have clear physical health diagnoses. So something like Crohn's or colitis or celiac, or really any number of kind of physical health diagnoses with all kinds of physical symptoms, who then also have things going on in their kind of mental health life, whether it's just coping with their symptoms, if they're, I'm a teenager and I have IBD, how do I cope with the fact that I have to run out of class a bunch of times a day, or I'm worried I'm going to have, a diarrhea accident in front of everybody, or I have a super limited diet, or I have celiac and I can't eat pizza like everybody else eats, right? So they have kind of things going on in their head, but it's specifically related to these sort of clear physical diagnoses that they have. So somebody's made a physical diagnosis, but we help them cope. So these are kids that wouldn't necessarily show up in a behavioral health office. We're more likely to meet them over with our subspecialist partners. They're more likely to schedule a belly appointment. Then we have my favorite things, which are those two little circles in between. And they're things that are neither clearly behavioral health or physical health. And two ways to think of those are all of the things that are functional diagnoses. So the functional abdominal pain, functional dyspepsia, kind of all of those things that don't have a clear physical cause, but they have clear physical symptoms, but they also seem to be really, really related to something that's going on kind of in the behavioral health life of the kid. And then the second area where there's really strong overlap is the group of things that are physical sort of diagnoses, but have behavioral solutions. And that's actually probably my favorite group of kids to work with. And these are kids with things like encopresis and chronic constipation, lots of toileting concerns. Encopresis is a clearly physical diagnosis, but the solution is really behavioral. So we might get involved and work with kids in that capacity. And we're going to talk a little bit more specifically about each of these groups. So Mithra, if you want to advance. Thank you. So psychological and psychiatric conditions have real observable physical symptoms. So these are messages, I sort of think of them as messages going southbound, right? So your brain has sort of had an event, it's had a thought, it's fired up some synapses, it's sending some neurotransmitters, and those are traveling down through the body's messaging system and impacting the way that your gut or your sort of, that whole kind of belly system is working. And so kids who are stressed, anxious, who've had trauma, who are depressed, can have a whole sequelae of somatic symptoms, not limited to, but definitely including basic belly pain, nausea, vomiting, diarrhea, constipation, loss of appetite, over appetite, and so on. All the things that you can think of that a kiddo might experience in their gut, they could be experiencing as a result of stress, depression, trauma, really lots of things. And those are, like I said, those are the kids that typically end up kind of entering the system on the behavioral health side of things, but not always. Sometimes they might start with the pediatrician. So, the kiddo will be complaining about a lot of belly pain, and the parent will make an appointment with the pediatrician and be like, okay, let's get your belly checked out. And after you do some questioning and some sort of listening to what's going on, it becomes pretty clear that the physical experience is real, but it's possibly it's sort of like what's driving the bus. So is a physical thing driving the bus, or is a stress and anxiety thing driving the bus? And for many kids, stress and anxiety drives the bus, but they're having real observable physical response. Okay, go forward. So anxiety has clear sort of ramifications in the body, including even for kids as young as toddlers. So we know that when the body fires up its fight or flight response, that causes a real cascade of different stress hormones and neurotransmitters, and they all can sort of land in different places of their bodies. You might have kids experiencing headache, dizziness, disrupted sleep, things like hair pulling, even toddlers, even kids as young as 1 or 2. You might see nail biting, sort of licking their lips and they end up with red chapped lips, or biting the inside of their cheek, dry mouth and coughing. difficulty breathing, chest pain, complaining about their heart, and definitely all of the stomach stuff, nausea, vomiting, diarrhea, constipation, cramping. So we always tell folks to start with the physical. You want to rule out anything physical going on for your kiddo. And then after all those boxes have been checked, then sort of come back and see us, and we can sort of work on what we then think is driving the bus, which is the stress or anxiety. Forward. This is a sort of a direct result of the fight, flight, freeze response, right, in our sympathetic nervous system. When we're under stress, when we're under threat, it's really not a good idea to be sending energy and effort to things like digesting your lunch, right? We can worry about that later. The first thing your body needs to do is to kind of get you out of the dangerous situation. The problem is that often the dangerous situation isn't a sort of a single one-time event that kind of then gets resolved, right? If we're talking about school as a stressor for kids, that's not resolving anytime soon. We're going to send you back day after day after day for all the hours of school. So kids can get into a cycle of kind of chronic stress, right? Where their sympathetic nervous system is kind of chronically turned on. And we're going to pay a lot of attention to this idea of the gut-brain axis. As we learn more about kind of how things really truly work, right? There's sort of a superhighway between the brain and the gut that goes in both directions, which makes sense. Our brain needs to be able to direct how things are going in our belly, but our brain also needs to know what's happening in our gut. You need to know when it's empty, you need to know when it's full, you need to know when you ate something that you shouldn't have eaten, or when there's some bugs in there that are causing situations. So there's a sort of that communication system sort of outside and in addition to the body's regular communication that make really our brains and our bellies just sort of tightly linked and really omnipresent in terms of stress responses for kids. Forward. The things that we do to address the situation when we think that it's anxiety or stress or depression or one of the mental health concerns driving the bus is we do what we would do for anxiety or stress or depression. So depending on age and severity, we might have a psychiatry referral or talk with a PCP about trying some anti-anxiety medications. We also know that therapy works really well to help kids address stress and anxiety. And cognitive behavioral therapy, right? CBT is the thing that everybody recommends now for most everything. It actually turns out, though, when you look at the literature, that in treating anxiety specifically for kids, interventions that prioritize exposure over coping strategies are more effective. So you want to think about interventions that help kids sort of face the feared thing successfully over spending a ton of time with more coping related, let's talk about deep breathing, let's figure out what your coping strategy is. It's really the big meta-analyses show that interventions that use exposures to help kids get over the feared thing are more effective. You can also do CBT with parents only and successfully treat child anxiety. So there's something called SPACE, which is out of Yale, the Child Study Center, a guy named Eli Leibowitz. He's done a good amount of work and published a bunch of books that show you can actually pretty effectively treat child anxiety without ever seeing the kid, just by kind of coaching the parents how to help the child when they're having an anxious event. And those kinds of approaches are really helpful in treating the anxiety and then subsequently seeing a reduction in the GI symptoms. Forward. There's just some quick exercises, things that can turn on the parasympathetic response and turn off the sympathetic nervous system are really helpful in the moment. So things like teaching belly breathing or bubble breathing. There's lots of different breathing sort of strategies out there teaching kids progressive muscle relaxation, which is what they call robots, jellyfish, and towers, right? Teaching kids to identify tenseness in their body and then kind of voluntarily relax it. Those are really helpful coping strategies to help kids manage anxiety in the moment. And they're usually a main focus of the first part of treatment. Forward. The second area, right, that second big circle, are physical conditions that have psychological symptoms associated with them. So I like to think about those as the messages are going northbound, right? So the problem is sort of occurring in the gut and things are flying north. And we see this a lot with kids who have all of the IBD kind of things, and also GERD and the refluxes. Forward. And we're not totally sure where those messages come from. It's probably all of the above. There's definitely vagus nerve involvement, right? That's the superhighway, where the messages kind of travel from the brain and back again. We're learning more about microbiomes and think that gut flora and gut bacteria probably have a role to play in terms of messaging how things are going. And it's likely that neurotransmitters are playing a role because, you know, the gut has ways to produce serotonin and dopamine just like our brains do. And so if things are kind of off kilter in the gut and it's kind of, you know, sending panic messages or not, you know, sending the appropriate messages, it can actually cause our brains to sort of act as if we were anxious, right? So things are off kilter in the gut for whatever reason. The gut is sending sort of emergency messages back to the brain reads those. And so kids can actually feel anxious. They can have symptoms of anxiety or depression that are being driven by their kind of gut health and gut symptomatology. Forward. So this is a super simplified version, but I like it because it helps me understand a really complicated kind of idea, which is that, you know, we've got physical connections between our brains and the guts. We've got the vagus nerve, but we also have these chemical sort of messengers, right, between our neurotransmitters and our microbiome. And I think it's really interesting to note that we kind of think that our amygdala, it's influenced by our gut microbiome, that the little bacteria in our guts are sending out some kind of chemical messages that are picked up by our amygdala. There was that really cool study they did out of Stanford a couple of years ago that showed people who have more of a certain kind of bacteria in their gut report being more social and kind of being in a better mood. So there was this idea that those bacteria wanted you to go out and mix and mingle with other people. And so you would have a better chance of sort of sharing that bacteria with others, and they could colonize new hosts. So I think there's a lot more going on there that we realize, but it's safe to say that when things are out of sorts in kids' guts, it's going to contribute to things also being out of sorts in their brain. Forward. So we help in similar ways. We definitely, a big role that we play is to make sure that kids and families are able to follow whatever their prescribed regimen is. We help a lot with adherence, particularly with complicated regimens or complicated families. We also might do interventions that really impact that, either the physical or the chemical connection. So things like mindfulness-based stress reduction, MBSR, that's the John Kabat-Zinn stuff out of Boston from the early 80s. There's really been demonstrated efficacy that if you do mindfulness-based stress reduction, it can alter gut functioning and via the vagus nerve probably, but generally improve the physical symptoms of like IBS and IBD. Meditation and relaxation strategies. And there's some evidence that acupuncture is also beneficial in kind of helping address those complexities. Forward. Then we have our functional diagnoses, which are partially physical and partially kind of behavioral health in a really complicated bidirectional way. So things like the irritable bowel syndromes that are really, really impacted by anxiety, functional dyspepsia, abdominal migraine, and then our favorite catch-all, functional abdominal pain, NOS. Forward. This is a great article that I found that kind of has this little interesting drawing about the development of functional abdominal pain. And it's a really multifactorial, complex picture that involves kind of the genetic predisposition, plus sensitizing medical events and factors, plus sensitizing psychosocial events and factors, which makes sense, right? If we think it's a problem that's coming from both ends, it would make sense that you would have kind of triggering events from both ends, that there would be things going on in the brain that would contribute, and also things that would be going on in your body that would contribute. But what they result in is this kind of brain to gut loop that gets turned on, right? They call it central hypervigilance, and a disordered microbiota gut-brain axis, visceral hypersensitivity and dysmotility. So fairly complicated interactions here. Forward. And I just put this up here because it shows what families have to go through before they end up with a diagnosis of functional abdominal pain. This is just one example of a workflow when you're trying to figure out what's going on with a kid. So a kid shows up in the office and says, oh, like my belly hurts. How do we figure out what's going on? And this is a really frustrating experience for families because there's a lot of, maybe seeing multiple specialists or going to appointments where there's no clear diagnosis, or getting the message that somebody's telling you that your child's physical symptoms aren't really real, that they're sort of all in their head. And that's something that we always like to focus on. Even when kids end up with these functional diagnoses, their physical symptoms are very real, and they're definitely experiencing them, and they have real physical causes that just happen to be related to the stuff that's going on in their head. Forward. So we probably do see, right? So you need to do physical health interventions with those functional diagnoses to help people manage symptoms. We need to do behavioral health interventions to help people manage the kind of the moderating or the contributing factors that are going on. And you kind of do them all at the same time. Forward. And then just a quick turn through the kind of the body and the behavior, right? So the diagnosis of encopresis, I work a lot with kids with encopresis. The root cause is definitely physical. It's typically constipation. You may end up with constipation as a kiddo because you are withholding. So you might have a fear of toileting for whatever reason. Sometimes just the toilet is really scary. Sometimes the sensory experience of being on the toilet's really scary. Sometimes kids have had a painful stool even before they were verbal. This is really kind of tough for parents to understand, right? Even, a 9 or 10 month kiddo could have a really painful stool and their brain just decides we're not going to do that anymore. Kid diet and drinking habits are not always the greatest, so that can contribute to constipation. There can be lots of medical contributors from things like Hirschsprung, right? Like actual, physical changes to just motility or just kind of like tendency, or you could just sort of be lucky and the kind of person that gets constipated and it shows up when you're a kiddo. Forward. Once you have had that constipation, particularly if it was a really bad event that kind of involved some sort of stretching and, impaction, and the kid gets into the cycle of withholding because of pain, then the stool becomes hard and painful. So they want to avoid the bowel movement to avoid this expected pain. They end up impacted. And when kids end up impacted, they sort of lose their voluntary control of the muscles and the sensation. They lose that rectal anal inhibitory response. So they can't feel that they need to go. And even if they did feel it, they couldn't make the muscles work anyway. So they get caught up in a cycle. An adult notices they haven't gone to the bathroom in a while. They give them some kind of stool softener or some other like X-Lax. It kind of cleans them out, but the situation is sort of ripe for occurring again because the kids afraid of a painful stool, but they can't feel that they need to go anyway. So as soon as they get cleaned out, they can't feel that they need to go. They couldn't push it out if they could feel it. And they're also not interested in going because it might be painful. So then they just get constipated again. It, you know, kind of reaffirms everything that's going on in the body. They get cleaned out and then the cycle goes around again. Forward. So the intervention sort of goes in order. First, we have to have a physical intervention. They usually need cleaned out. They also need to follow with a daily medication so that the constipation can't happen again. Then we come in on the other side with the behavioral interventions. We need to make sure that kids know what to do on the toilet. We need to have them regularly sit on the toilet, and there's usually a lot of positive reinforcement and behavior planning that goes into there. And we can do positive reinforcements for sort of successful lack of soiling. And then there's a ton of family support because this is a very intensive plan that has to happen. You can't miss doses of medicine. You can't miss sit times. You have to argue with your kid who's being oppositional about whether or not they need to go and do this. So we do a lot of help for families for scheduling and setting and following reward plans, and then just checking for any sort of unintentional reinforcement or secondary gain that might be happening. Forward. So that is like a flyby. I ended up talking longer than I was supposed to, but that's sort of like a flyby of all the places that psychologists might get involved with kind of kids and their sort of, you know, their GI sort of life. I have lots more references than this. If anybody is interested or you want to talk specifically about cases, I'm more than happy to do that. But it's a really kind of ubiquitous, you know, kids in their bellies is sort of a ubiquitous problem. So even if you don't end up in a, you know, kind of a specialty area, even in just primary care, you're just, you know, you're seeing kids in general, you're likely to run into these places where kind of the gut-brain axis is making itself known. So that's all I had.
Thank you so much, Dr. Ludrowski. That was a really wonderful presentation. I'm sure there's like so much more that you could get into even on top of that. I feel like it's such a complex situation. And but no, it was wonderful. We really appreciate you presenting on that. Anyone with questions or comments, feel free to unmute or chat in, and I can read out the chat as well. So thank you, Elizabeth. And I was going to say, Dr. Ludrowski, so I'm half Japanese, and my mom was telling me in Japan, they teach their, like in preschool or kindergarten, I don't know like what age, but I know it's like at a young age, they kind of teach the school age kids how to regularly go to the bathroom. So like in the mornings before the class will start, I think they do like, I'm not sure exactly what the process is, but I know they like, it's a normal part of the school day. So they'll be like, okay, guys, like, let's all go to the bathroom, like try to sit and like make sure it's regular and start your day off regular. It's kind of like that. So I don't know if you've heard of that or if it's something that might be incorporated in our school systems. But when I heard that, I was like, oh, that's interesting.
You know, I hadn't heard about that, but I kind of love it because one of the things that we see often is that, you know, even really little kids, right? We often have families where both parents are required to work. Usually there's, you know, there's a sort of caregiver, but sometimes even multiple caregivers, right? One parent drops off, the other parent picks up, or maybe like grandma picks up and we make a pit stop at grandma's house and then the other parent picks them up. So what'll happen is that kids it'll be 2, 3, 4 days, a week, you know, a week and a half. And none of the adults have put together that the kid hasn't gone to the bathroom because you just assume that it happens on somebody else's watch. You know, they're in school all day, or, you know, you figure that they pooped when they were with dad that morning or whatever it is. And so the idea that we could like somehow like structure it into kids' lives where we're just like, actually, this is a thing that everyone needs to do and you'll feel better if you go to the bathroom. It's really awesome. And maybe could catch some of those kids that might otherwise get caught up in that constipation cycle.
Absolutely. Thank you.
this is so legitimate. Especially when my 4-year-old wants more cheese, I have to say, okay, when did you poop? Because I'm gonna, you cannot have any more cheese if you have not gone to the bathroom today.
That's funny. That's like me. Can't have any more cheese.
No more cheese unless you have pooped today. So I totally get that. Different schedules, different people. That's tough. And this terrifies me because the idea of having to do the sit routine and the not missing meds, this would not be fun.
The interventions are really rigid. And it's really like if you have just like a regular life that's busy with kids, it's just, you don't need anything sort of special about your family to really have a difficult time implementing this intervention. It's really a lot. So yeah, make sure your kids are pooping regularly is like the take home today.
I think it's hard too, because like what's regular, to some people are different for another, but I think there's some kind of standard, like, I don't know, like 3 times a week or 4. I run on the CN, so sometimes, or if I'm like a kid still, like if I'm nervous in a new place, I won't go for like days. Like, so my dad and mom are like, you need to just do it at a certain time, just like Mitra was talking about, and you guys like clockwork, or try to make it like that. But it's just, everyone's different. Or what do you eat? If I had too much cheese.
And the hardest, honestly, just gut stuff in general, not specifically the encopresis, is really, really hard because everybody is different. There's like no standard. I can't say like, if you eat something at 4, you should need to go to the bathroom at 6, right? Some kids, some people go to the bathroom every day. Some people go 3 times a day. Some people go every 3rd day. There's like a huge variability. And so families will spend a lot of time playing detective. The kid will have a stomach ache and then they'll be like, well, what did you eat for lunch? Well, what did you eat for breakfast? Well, what did you eat for dinner? And you can just really get stressed even by the detective work that goes into trying to figure out what's going on with your child's gut, because we don't have there's no window, like you can't see what's going on in there. And we also have no idea how long it takes. People be like, well, I really think it's dairy, but then it turns out they don't have a dairy allergy at all. And it's something else altogether because, you eat dairy and then you feel sick, but you don't realize that it can't be the dairy because it's not affecting you for 8 more hours or whatever. And then to try to get these answers out of a 3-year-old is like.
I just retired from 20 years in public education. And the last 5 years have been with 2nd grade, and I don't know how many times. Miss Bailey, my tummy hurts. Okay, go poop. Go. Did you? But I did. No, go. But it's school. No, go. And so that was like my go-to thing all the time. Just go. And 90% of the time, it worked.
Well, it's also terribly boring, to sit in the bathroom and you have to stop doing what you want to be doing and take yourself away from all of your stimulation and yes, your phone, right? You have to get off the Xbox and go to the bathroom, and kids are just like not all about that. And it turns out that if you withhold long enough, your brain just stops. It's just your gut just stops sending the message. It's just like, okay, well, I guess we're not going. So you just don't have to feel it anymore. So if you're sort of devoted to the process, if you just like withhold long enough, you end up in having serious constipation and probably encopresis. So those are a lot of kids who really rate the kids that are like having to sit on the toilet for 5 minutes is akin to like death. Like it's so boring. So we'll do a lot of like help and support with families to figure that out. But you can't play a video game or you can't be on the phone in there because then you forget to do what you're supposed to be doing.
That's such a good point. I didn't even think of that either. You just have to go in there and be patient and focus on one thing. Yeah.
So it's not okay to practice Duolingo on the.
finish after every like subsection, right? Like you finish 3 and then you exercise, then that's perfectly fine.
Awesome. No, this has been great. And I really found it interesting when you're mentioning happier people due to the bacteria in their stomachs. I think that's rather interesting. Now, just a quick last question. What about, like, I take probiotics. I don't know if they're doing anything. I think they're doing something, but do kids, do they have that? Do you see a difference with that and like therapy? Because I think it is like gut mind is very interesting. I think the more we develop studies and research in it.
I think it's a hugely under-researched area. I think it's entirely possible that things like probiotics or fecal transplants probably do have some kind of impact, but I don't think we know what yet. I don't think we know what that does for adults, let alone kids. But I think it probably does something, and it's definitely a huge area of research. You'd have to really figure out your research design though, right? But yeah, so I think like we're going to be learning like more and more and more about the importance of and at some point we're going to know enough that we look back to what we're doing now, we're going to be like, that was so silly, that doesn't have anything to do with what's going on. But I definitely think something is going on, and we know enough to know that our gut biome is hugely impactful, even when it comes to like our feelings and our behavior.
Which means that the concept of being hangry might be legitimate.
I think it's really legitimate.
Oh my gosh, do I get hangry?
I can attest to that personally.
Feed me, please. But I've gotten better. I've started to do like the fasting thing. So I've gotten better at my hanger control, but yeah, it's real.
Any other questions or comments from the group? This has been a fun conversation. Very informative as well. And Dr. Ladrosky, I'll be sending out a recap email, and I'll attach your slides as well. So if anyone has any follow-up questions or anything after the fact, I'll make sure to send them your way.
Absolutely. Thank you so much, everybody.
Thank you so much, Dr. Ladrosky, and thank you all so much for coming. The only announcement that I have is that the next session will be on November 2nd, and Amanda Newhouse will be presenting on treatment planning and coping for kids. So thank you all so much, and we look forward to seeing you all next time. Take care, everyone.
Bye.